For our last presentation for the conference, we have Emily Johnson. She's a pediatric urologist at Lurie Children's and associate professor of urology at Northwestern Feinberg School of Medicine. Dr. Johnson is a member of the Fertility and Hormone Preservation and Restoration Program at Lurie Children's and is the lead surgeon for fertility preservation in pediatric patients with differences of sex development. She pursues health services research with a focus on fertility decision-making for transgender and DSD patients. Emily.
Thank you so much. Thank you very much to the organizing committee, Kyle, Monica, for your invitation, and to everybody for staying for I was calling myself the caboose, for staying for the last talk. If you need to wiggle or stretch, I won't be offended, it's fine. I know we're over time. I'm gonna try not to rush, but I wanna sort of get the information out there, so give me a signal if I need to move along. As the last talk of the day, we're going to review a bit about fertility preservation and DSD. I feel very humbled to follow Allison. I'm not somebody that identifies as intersex or that has a DSD, and I think having the perspective of somebody who is a professional and has different identity is super valuable, so I'll do my best to give this topic justice. This is our roadmap for the next few minutes. Just give a brief introduction to make sure we're all on the same page. I'll review some points about our research protocol. At Lurie, we've decided to sort of separate out the research protocols for oncology patients, DSD, trans, et cetera. I have a few case examples and then some thoughts on future directions. So first, just a little bit of introduction. Again, so we're all on the same page. This is sort of the academic definition of DSD. You'll see I use a lot of different terms interchangeably because there is no one accepted term, but from the sort of academic perspective, DSDs are considered congenital conditions in which development of chromosomal, gonadal, or anatomic sex is atypical. Again, there's lots of other terms you'll hear: intersex, differences of sex development, the genetic counselors like CARD, congenital conditions affecting reproductive development, and this is a wide range of conditions that fall under this umbrella, many of which affect fertility potential. And I just want to say there is certainly some overlap where some individuals with defined DSD conditions do identify as trans, but they are not the same thing. Many individuals with different DSD conditions are at risk for impaired fertility for many reasons that you'll see on this slide. Abnormal gonadal development, the traditional recommendation for gonadectomy at the time of a DSD diagnosis, et cetera. And then you'll see animating in sort of where some of the different DSD conditions fall. So Turner syndrome and variations, gonadal dysgenesis sort of fall into the abnormal gonadal development box. You'll see anatomic barriers there, and then things like overtesticular DSD or 5-alpha reductase deficiency fall into that abnormal hormone production or action box. I think it's important to remember that the sorts of options that we've talked about during this conference, this idea of experimental fertility preservation for these patients, we sometimes call it cryopotential because we're preserving tissue in the hopes that the science that we've been hearing about will develop to the extent that these folks can use their tissue to have a biological child in the future. And this concept of cryopotential is really most relevant to certain of the conditions that you saw on the prior slide. So many of our patients that we counsel about experimental fertility preservation options are folks with 46XY DSD conditions. Also, some with chromosomal differences like mixed gonadal dysgenesis or Turner syndrome with Y chromosome material, as well as ovotesticular DSD. And our prior work has shown that this is really an important concern for patients and their families. Often when a baby or a young child comes to our clinic, this is one of the things that families bring up. Like even before I might think to bring it up, families will wonder if there is the potential for fertility. And interestingly, when we looked at our gonadectomy specimens, sort of from our historical data when we were doing gonadectomies, I would say much younger for a lot of patients, this gets tricky because there are actually some form of sort of immature germ cells in many patients with DSD. And what you see on the right is that the presence of germ cells overall does decline by patient age, so they're having sort of early gonadal failure with a lot of these conditions. And so that's somewhat tricky and at odds with some of the counseling where we're thinking about the potential for preserving gonads in a lot of these conditions. As I kind of alluded to, the paradigm is changing for gonad management in DSD, where the traditional paradigm, not unlike the transgender population, infertility was assumed. If you were diagnosed with one of these conditions, you're infertile, your gonads come out, you're at risk for cancer, and that's it. And that's just not how we counsel our patients anymore. We have expanding knowledge about fertility potential, as very clearly evidenced by this meeting, and along with that, there's an individualized cancer risk assessment. So, complete androgen sensitivity syndrome is not the same as partial androgen sensitivity syndrome, and we help the family sort of understand the differences in their risk. And with that paradigm, gonadectomy is still definitely discussed and recommended in certain cases, but it's much more individualized, and when possible, we have the patient involved in making the decision about gonadectomy. So with that sort of background in mind, at Lurie, we have expanded the pediatric fertility preservation options that were really developed for patients with cancer and other patients who are having stem cell transplants to our patient population with differences of sex development. And the discussion about this started over a decade ago, and as we sort of started to think about who this might apply to and talk to our families about this, the patients were here and there enrolled as planned exceptions to our oncology protocols. You see that little kid there with the suit doesn't quite fit? That's sort of what was happening. Like, it worked, from a procedural perspective, but it wasn't quite the right fit for a lot of our patients. And that was because there were separate protocols for ovarian and testicular tissue. There's cancer-specific language, so the IRB talks about patients with cancer, and for DSD, you're doing the gonadectomy because you think they might have cancer, but they don't actually have a cancer diagnosis, so it's confusing. And then the original versions of these protocols had more binary gender and sex-specific language, where you assume that people with sperm identify as male, people with ovaries identify as female. We now know that's not always true, and so sort of writing this protocol also helped us discuss how we might update our oncology protocols as well. So many of you have seen some version of this slide, I just can't get rid of it, but I call it a labor of love because it was like a year-plus long process. Aaron and Monica are nodding, to sort of modify and think about how to write a protocol for patients with DSD who may be eligible for experimental tissue cryopreservation, and that paper was the academic result of the labor of love. This just sort of goes through some of the same information that I was alluding to on the prior slide, but I like tables, so I think it's nice to think about it this way. So in the oncology protocol, the tissue type is either ovarian or testicular, and they're in two separate protocols. And for the DSD protocol, we have ovarian and testicular tissue all contained within the same protocol, and that's because some patients, we might not be sure what type of tissue they're going to have. Other patients, like a testicular DSD, they actually might have both types of tissue present in the same individual. Obviously, the conditions are different, and for DSD patients, the cancer language can be really scary and may not be directly relevant to their current clinical situation. And then again, the language around gender and sex previously assumed that the tissue type matched the patient's gender identity, whereas the DSD protocol left that more open. So here's sort of how the counseling goes in a very simplistic way. We meet and talk about the patient first as a multidisciplinary DSD team, and then they have their clinic appointment, regroup to discuss the patient care plan, and the clinical team, based on the discussion with the family, if this is relevant, sort of thinking about a gonadectomy discussion, the team would discuss again. And then the consultations that are listed on the right, not every patient gets all of those consultations, but depending on the discussion, depending on the patient's needs, if they're interested in fertility preservation after they've made a decision about gonadectomy, they have a separate consult with the fertility preservation team. And then sometimes there's more things that need to be worked out related to psychology or ethics or whatever. So that is very individualized to patient, depending on the patient's situation. We definitely make sure to emphasize the experimental nature of fertility preservation in this patient population. So just on the slide, you'll see some of the things that are sort of what we say. There are many ways to build a family. Advances in science are necessary for this tissue to be used to make a baby in the future. For most of our patients, no baby has actually been born using gonadal tissue from a patient with this diagnosis that has been frozen in this way. So trying to be as clear as possible that we're doing this now because you've made a decision about gonadectomy and this is the opportunity to save the tissue, but this is not a guarantee that a baby is going to come from that tissue in the future. So let's say a patient decides on a gonadectomy, they decide to enroll in the fertility preservation protocol, the DSD protocol. The gonadectomy happens, half of the specimen is sent to pathology and half is saved for temporary cryopreservation. If the pathologist identifies any concern for a tumor on the pathology, then the remaining tissue is recalled for further evaluation, and the patient is no longer eligible for experimental gonadal tissue cryo. If there's no tumor identified, then the findings are documented, the pathology report is released. Are there germ cells? Is there any evidence of tumor? Obviously, in this case, no. And then we discuss the findings with the family, and they can make a decision. Are they going to send it to long-term storage? Are they going to donate it to research, or will the tissue be discarded? And they fill out a form, and that gets saved, so everything is documented. So the DSD-specific protocol started in 2018. We have a few patients dating back to 2013 that are not included in this slide that were enrolled as the planned exceptions to the oncology protocol. But in the DSD-specific protocol, we've had 10 patients enroll. 9 of them identify as female. The median age is about 11. One patient had most had bilateral gonadectomies, but one had a gonadectomy for an ovotestis. That was a unilateral procedure, but most are like patients with similar gonads on both sides, I would say, like Turner with Y, for example. And just because this is recent, I put it in here, and I have a case later that will just illustrate this, but we've had 2 patients where we went through that left side of the pathway where the tissue got recalled recently in 46XY complete gonadal dysgenesis. So we've gone through the whole discussion. They've met with everybody, made the decision about gonadectomy, deciding they potentially want to save tissue, and then they've had tumor cells. And so we had to sort of work through that process. And half of preserved tissue so far. This just shows you kind of the range of diagnoses. So the patients who have germ cells and don't have malignancy, typically mixed gonadal dysgenesis. We had 1 patient with ovotesticular DSD who saved both ovarian and testicular components, and we had 1 young lady with a complete androgen sensitivity who saved tissue. The 2 at the bottom are the 2 that had tissue recalled, number 8, number 10. So our early experience with experimental fertility preservation for patients with DSD shows that this is technically feasible. We can do it safely, save the tissue. This process is a lot of people that these folks talk to, but this process works for families, and we've sort of worked out some of the flow, I think. Really no additional surgical morbidity, and there's adequate tissue to rule out malignancy. The protocol is a template for others who might be interested, so we're happy to share. Definitely a team approach, and I mentioned that bisected gonad, so half goes to pathology, half gets temporarily stored, and then making final decisions after that pathology is available. And then lots of things we still need to work out, like all of the topics that we've discussed over the last few days. Who is this best suited for? Diagnosis, I showed the slide about age earlier. How do we think about that? How do we counsel families about that? And then what can we do to better understand the quality of the germ cells and maybe give patients a better idea of what to expect as far as technological advances in the future? So here's just a couple of cases before I wrap up. The first one is a patient with partial androgen sensitivity syndrome. So this is a kid who had partial androgen sensitivity diagnosed at 6 months old. And the family elected for a female sex of rearing, and the patient expressed a female gender identity. At the time, because this was many years ago, this was at the time where early gonadectomy was recommended, and the family said no, thank you. They actually inquired about fertility preservation at the time, but it was not something that was really talked about or available in this scenario. And then fast forward a decade, this kid is 11, expresses a strong female gender identity, but starts experiencing some undesired masculinization with puberty. And so at that point, options for gonadal management were discussed with the family again. This is a neat case because the kid was 11 now, so she could participate in the decision about gonadectomy and gonadal tissue cryopreservation. And she expressed a desire for possibly having a biological child in the future. So they were counseled about the experimental nature, and they understood that the patient had female gender identity, but the cryopreserved tissue would be spermatogonia. And so she had a gonadectomy and underwent tissue cryo. You'll see the pathology on the right. Case number 2 is an example of GTC for a patient with mixed gonadal dysgenesis. So this is a 1.5-year-old who presented with atypical genitalia in infancy. Karyotype is 45X, 46XY. The child came and saw us, had a multidisciplinary counseling around the diagnosis, and at 1 year of age, to confirm the diagnosis and get more information, she had a diagnostic laparoscopy. It showed a left streak gonad, which was removed, and what appeared to be a right dysgenetic testis. The dysgenetic testis was left in place. The family came back and spoke with the team again, and after many conversations, this slide is a gross oversimplification, but after many conversations, the family elected for a right gonadectomy as well, and elected to preserve that gonadal tissue from the right side. So this is a surgical image, so laparoscopic view of the pelvis. Patient's right gonad is on the right side of the screen. Uterus is in the middle. That's the right dysgenetic testis that was preserved via gonadal tissue cryo. And that's just what a left streak gonad looks like if you're curious. This is a pathology from the patient's dysgenetic testis that showed a thickened basement membrane, and there were germ cells present. They were, reduced compared with a typical testis, but certainly had germ cells present that were preserved for this patient. And case example number 3 actually happened last week, so I just put this in there because I think it's important to talk about the cases when gonadal tissue cryopreservation maybe couldn't happen. So this is one of the Swyer syndrome cases. This is a 3-year-old little girl with 46XY complete gonadal dysgenesis. The other name for that is Swyer syndrome. She was referred to our team for discussion of the condition as well as gonadal management options. And this is one of the diagnoses where the chance of tumor is actually much higher than in many DSDs, and the chance of germ cells is much lower. And so it's one of those where, a lot of times we try to do shared decision making and give data and not say what I would do, but if someone asked me what I would do, this would certainly be a case where we may lean more towards gonadectomy due to tumor risk. The family had several multidisciplinary visits with our clinic and made the decision for a bilateral gonadectomy. After that decision was made, they met with the fertility preservation team and decided to attempt gonadal tissue cryo, depending on the findings. So this is the image from her diagnostic laparoscopy. You'll see the uterus in the middle and the right streak gonad on the right. There was no gross tumor seen intraoperatively, but on a Friday, of course, Friday at 4:30, the pathologist paged me, which is always hi. And he told me that there was a focus of gonadoblastoma in the right streak gonad. So Dr. LaRonda recalled the remainder of the tissue from her lab and sent it to pathology. And on the right, you'll see the final pathology. So Friday, pathologist calls me. I say, oh no, okay, we need to recall the tissue. Let's figure this out. Monday, have a conference call with the whole team. The fertility preservation physician and lab leads are sitting right here, and we all spoke with the pathologist just to kind of talk through the workflow. A few days later, the final pathology returned, which fortunately for the patient showed there was no dysgerminoma or tissue or the malignant cells that had the potential to spread, but there were tumor cells, and so this patient doesn't need any more treatment, but it shows why we have these discussions about gonadectomy. This was a tricky one because the pathologist then said, can I release the pathology report? And I said, let's wait. Let me talk to the family before it goes into my chart, because we have this thing where now, once the pathologist signs the report, it goes directly to the patient potentially. And so I asked him to wait until I spoke to the patient. So I called the mom, let her know, and kind of went through everything with her. And then the pathology report was released, which I think she appreciated, not reading that without context. So just some ideas that we've been thinking about as far as expanding the protocol. Right now, the protocol is only for patients who are electing prophylactic gonadectomy, but we've been asked, different families have asked whether we could do a biopsy and preserve tissue without, more similar to our testicular tissue cryopreservation protocol. Other things that families ask about, so patients who have symmetric gonads, like the XY gonadal dysgenesis or Turner syndrome with Y chromosome where the gonads are the same on both sides, well, can't we just take one out? And the answer right now is no, but we found, at least with our IRB, if there is a clinical rationale and a patient that's interested, that they're open. And so with improvements in malignancy risk assessment and improvements in fertility potential assessment, I could imagine a scenario where this might be possible. Just one final sort of set of comments about Turner syndrome with Y in particular. because I think this is the case where we get a lot of questions and where we are trying to think about how to balance. It's a good example for balancing tumor risk and potential gonadal function and fertility. The risk of tumor in this case is maybe 10%. There are some reports of at least partial spontaneous pubertal development for girls with Turner syndrome and Y chromosome material who keep their gonads. And there are case reports of spontaneous pregnancy and birth. So it's tricky because most of these patients have traditionally had their gonads removed. So maybe this would be the ability to have endogenous puberty or even pregnancy might potentially be able to be higher. So right now, the current Turner syndrome guidelines still recommend prophylactic gonadectomy, but there's a relatively low level of evidence. And so our team has taken the approach of discussing gonadal function and germ cell tumor risk, counseling about oocyte cryopreservation if the patient is post-pubertal, and then considering GTC if they elect for a gonadectomy. But we sort of say, this is what the guidelines show, but this is what we know and what we don't know. And some patients have elected to retain their gonads and others have not. So this is the sort of, again, as I mentioned, the sort of things we are asked. Can we just remove one, even though there's the same risk in both? And we say, like, not yet, but maybe soon. And we are happy to partner with you to help advance the science and also advocate on your behalf with our hospital. So looking ahead, I think it's very clear that the advances in prepubertal gonadal tissue maturation do apply to this patient population. And it seems as though biological fertility may be possible for expanded groups, including the patients that see us in the DSD clinic. Patients and parents are definitely interested. We've, had colleagues ask us, isn't it weird for the families if the kid has sperm, but they identify as a girl? And for the people that picked to enroll in this protocol, no, it's not weird. Like, that's what they wanted. And so next steps are we can accept gonadal tissue from external sites now, which is new. So if other folks are interested in that, the Loranda lab. And then this idea of gonadal tissue cryo from either biopsy or unilateral gonadectomy is sort of active area discussion. So as I wrap up, I just want to thank the fertility preservation team as well as the gender and sex development program. This is a huge group of people that are involved with being able to offer this option to our patients with DSD. Many of these folks are in this room, so I just really appreciate your collaboration. I know we're a little over, but I'm happy to entertain questions either here or email or Twitter or whatever. Thank you so much.
I just want to say that was a fantastic presentation in record time. And I felt like you did a wonderful job explaining, the challenges that your team faced. And I really appreciate you sharing that information and kind of your roadmap. So that's all.
Thank you.
Kyle.
Thanks, Emily. That was a great talk. I was interested in your case number one because the histology, at least in some of the tubules, was really good, like almost complete spermatogenesis. And so I wonder, when you're consenting families to cryopreserve tissue, whether in that case you also would have the option to dissect the tissue and see if there were sperm.
I'm becoming more and more enamored. I'm sort of answering your question with a question a little bit, but I'm becoming more and more enamored with our collaboration with Dr. Halpern over at Northwestern, in addition to Bob Brannigan, and wondering if other folks have experience with collaborations between adult and pediatric urology. I think the short answer is no, we didn't really think about that for that patient. But I would love to for future patients. I just, it's a technique that I learned in residency and then don't do very often. And so I think it's a perfect area for collaboration between pediatric and adult urology.
So just to answer for what others are doing, I can speak for us. It happens that we process our samples not in the Children's Hospital, but we transfer them over to the andrology clinic, andrology and fertility preservation lab in the adult hospital. So it's kind of prepared for either thing. So in that case, we would. Only with families' consent, though. We're consenting them for an experimental protocol for tissue, and so this is additional education about there might be sperm. If there were, would you want us to preserve that sperm? That's a different process, and it's different than what the intent of the protocol was.
Yeah, I mean, I would need to learn more about the technical details to be able to do that counseling justice, I think, but I'm super interested, and Sarah and Barbara, super excited back there, so let's do it. What else?
Thank you for this amazing talk, and I think it's very interesting that you offer this opportunity for the DSD population. I would just have a question concerning the Turner syndrome, because we discussed it a lot in Switzerland. What is the best approach? Because, I mean, whether you have a mosaicism and then you have a chance of going through puberty, at least you have a chance, not everybody, of course, but then rather waiting a little bit longer, so then perhaps have the chance to do an oocyte retrieval. Because when you then take the tissue, and this is my point, I mean, when you have the tissue, we know that there is an acceleration in atresia, right? And so we know that 50% by retransplanting it later on is 50% is just lost due to the fact that you have it retransplanted. So it might even accelerate the atresia, that is the basic problem, even further. So I think it is hard for this population to really know what is best, so right. I would love to hear your thoughts about that.
Yeah, and you're talking about Turner syndrome without Y chromosome,
yes,
right?
Yes, absolutely. I know
yeah.
there's a different, I know, yeah, it's not the same, but...
It's not the same, but it's a very interesting point. I appreciate the question, because when we were working on the labor of love in like month 6, that was one of the big points of discussion, was whether to include patients with Turner syndrome who don't have Y chromosome material, who don't have an increased risk of malignancy, so therefore they would not be having prophylactic gonadectomy, sure. Whether to include them on the protocol or not. And ultimately, like, it was absolutely clear from our IRB's perspective, at least at the time, that if we want to do that, that needs to be a separate protocol, because cognitively that's a very different population. Yeah. So I know Dr. Gomez-Lobo at the NIH has an open protocol now for that patient population, but that at our institution is not something that's possible right now, although, you know, it's something we're certainly working on and thinking about a lot, and it's for those reasons. Yeah. They're not having another procedure. It could accelerate their ovarian insufficiency, et cetera. So I appreciate that comment. It's a really important distinction that these are like two very different patient populations.
Absolutely.
Anything else? All right, thank you so much for the opportunity.